Welcome, everyone. We're so happy to have y'all here for our innovation webinar series webinar this month, focused on transforming public health through the foundational public health services. I am Rena Chudgar. My pronouns are she, her, and I support our public health systems and services work here at the Public Health Accreditation Board, or FPHAB, and through our division, the Public Health National Center for Innovations, or PHAB. We're so glad to have y'all here to talk about kind of what's being coined as public health's moment right now, and how do we truly come together to truly modernize and transform our public health system into one where we have the capabilities and the resources to do the work that we need to do, to build with and for community, to have the right workforce, the right resources and supports needed to truly thrive, and how to make the FPHS available everywhere for public health to work anywhere. We're so excited for our presenters today to share some of their insights, their stories, their learnings, and their expertise around modernizing and transforming public health. Before we shift over to them, I did want to cover just a few logistics items for today's webinar. Our webinar is being recorded, and we'll make it available to all of you to revisit as you would like, and to those who are not able to attend today. The link to the recording and the slides and other follow-up materials will be made available by the end of this week via our website, and we'll send out a newsletter as well. To enable closed captioning, feel free to click the closed caption icon at the bottom of your screen, and that'll be enabled for you. And we encourage you to use the chat feature to ask questions and engage with each other throughout our time together today. Take a few minutes now to introduce yourself. Let us know who you are, why you're joining us today, where you're calling in from. And throughout, please do insert your questions, and we'll be sure we feed those into our panelists and presenters today. As we kick off, we did have a quick poll to get a sense of who's joining us in the room today. So if we can go ahead and launch that poll. And please go ahead and select your responses to both poll questions. Give folks a minute to respond. All right, and then Travis, if you could display the results. I think they should be displaying. So it looks like we have a variety of folks in the room today, from local health departments, state health departments, tribal health departments, national or state public health. Great. Well, thanks for joining here today. And I believe that to their second question, how familiar are you with the foundational public health services? We have folks who are hearing about them for the first time, a few more folks who have heard about them but know very little, a few folks who know a fair amount and are planning to think about how to use the FPHS, and then fewer in terms of you're using or they're embedded. So I think this will be a good mix of content and information for everyone who's joining today. So thanks for taking a few minutes to let us know who's here. If we go to the next slide, we just wanted to share a little bit about our plan for today. Our goal really is to share more about how the foundational public health services are being used for transformation nationwide. And we'll spend some time starting out with some context setting, some information about what the FPHS are, and talk a little bit about what FPHAB does and services and tools that we can support all of you with in terms of transforming and modernizing. And then we'll have a panel discussion and Q&A wrapped together with practitioners in action from Washington, Minnesota, and Indiana, who are bringing their experiences and expertise in doing this work to share with all of y'all today. So first, before we move to our panelists, I'd like to introduce Paul Kienert. He's the president and CEO of FPHAB, and he's going to take a few minutes to set the context of this moment in time, again, share a little bit about the FPHS and describe FAB and our programs and tools that support transformation. Paul oversees all aspects of FAB's mission and work, including transformation, accreditation related activities, partnerships, planning, and has experience from both the state and local public health leadership levels. You can read more about Paul in the bio that'll be put in the chat box. And we're so excited to turn things over to you, Paul, to share a little bit more, and feel free to share more about yourself so attendees can get to know you as well.
Well, thank you so much, Rena, and thanks everyone, and hello everyone. Really appreciate you joining us today for this webinar, and looking forward to the panel presentation, as well as hearing from you either through the chat or later. You'll have our contact information, and we'd love to hear from you directly. So I think if we can go to the next slide, I think it's true that all of us are feeling a degree of urgency in public health these days that's driven both by our recent collective experience with the COVID pandemic, combined with the new opportunities to update and transform our public health systems with the federal public health infrastructure program dollars. Next slide. I think that both our opportunity and our central challenge that we're facing right now are both summarized in this key finding from public opinion polling that was actually done in the late fall of 2021 by the Chan School of Public Health at Harvard with NPR, supported by Robert Wood Johnson Foundation. And as it says in the quote there, really public health has never been as visible or as misunderstood. And I would just note that the problem of trust that's kind of identified in this quote and in this poll was actually reinforced by a poll that was just done this very month in January of this year. That again, it was done by Morning Consult, and it highlighted the problem of mistrust in public health. So it's certainly a very, very current issue. And it kind of sets this dilemma for us, if we can go to the next slide, in terms of how do we transform and modernize our public health system in the context of the public understanding us or thinking that they understand us a little bit better, but having this feeling of mistrust for a variety of reasons. So I think that all of us have sought to be as responsive to these challenges as possible, with numerous important commissions and studies that have been going on over the past couple of years. That these studies have assessed and summarized our challenges in detail. They've made both policy and program recommendations. And these are kind of illustrated in just this graphic from the Public Health Forward report that was released about a year ago, and that many of us on the call today participated in some way in kind of shaping that report. So I would just note that now, thanks to the catalytic efforts of these commission efforts and reports, and the private foundations like Robert Wood Johnson Foundation and De Beaumont and Kresge and the Commonwealth Fund and the CDC Foundation, and actually others, even at the local level, like the Sunflower Foundation in Kansas, they've all kind of set the stage for this massive federal government investment in public health infrastructure and workforce. So we have recommendations, we have an understanding of the situation, and now we have resources to act. But what exactly should we be doing? So if we go to the next slide, What we'd like to share with you is that FAB is really ready to help. Based on our values and our vision and our mission that are all shown here, and in our role as one of CDC's national partners for the Public Health Infrastructure Program, along with our colleagues at ASTHO and NNPHI, we are here to partner with all of you, the front lines of public health practice, to help you rebuild trust in public health by ensuring excellence and bringing innovation to scale. Next slide. The foundational public health services framework is shown here. And FAB, through our Public Health National Center for Innovation, has been the steward of this framework since 2015. We have worked with partners across the country, some of whom you're going to hear from today, to make this framework operational, to make it practical. The FPHS is the framework for the CDC Public Health Infrastructure Program, and it outlines the unique responsibilities of governmental public health, those services and capabilities that must exist everywhere for public health to work anywhere. So as you can see, if you look at the details in this model, it has kind of two central features that define what we mean by public health infrastructure. First, the foundational capabilities are the 8 cross-cutting skills and capabilities that are needed to support basic public health protections and other programs and activities that are key to ensuring communities' health and achieving equitable health outcomes. The foundational areas above those capabilities are the minimum set of public health programs and services that are supported by the public health infrastructure. Community-specific services vary by community need and sit on top of this infrastructure. Go to the next slide. In version 2022 of the Public Health Accreditation Standards and Measures, we have explicitly identified 34 of the 84 measures as foundational capability measures. Health departments will not be able to be accredited if they cannot fully or largely demonstrate that they have these foundational capabilities and services. So supporting you through accreditation, through the accreditation process, and helping you achieve public health accreditation is one way that FAB can help you transform your health department. Go to the next slide. But I'm here to tell you that FAB is not a one-trick pony. We have developed a whole set of tools that can meet you where your health department is on your journey to transformation. Next slide. So here's a little bit more about some of these tools that were featured on the slide before. So our tools kind of range from a structured readiness assessment that can be done at both the individual health department level or applied and used across a statewide system, like they're doing in Nebraska right now. To service, we also have tools around service sharing and the workforce calculator. So we invite you to visit our website at PHAB board, so FAB board, all one word, .org for more details. If we go to the next slide. So I'd just like to conclude by paraphrasing Dr. Einstein, that we can't solve the public health challenges that we're facing today by using thinking that's rooted in the past. We need to innovate if we're going to succeed in transforming our public health system and regain the trust of our communities. Last slide. So here's my contact information. You'll have a chance to get these slides, as we've said earlier. But today we are really fortunate to be joined by a number of public health innovators who will share with you how they have used the foundational public health services to catalyze public health transformation in their statewide systems. So thank you so much. I'm going to pass it back to my good colleague, Rena Chudgar.
Thanks so much, Paul. And that was great. Just foundation setting and context setting as we go into the panel discussion. We did have one or two questions for you, and I think we have a minute or two for Q&A. And wanted to pose one, which is, can you talk a little bit more about if folks are interested in talking to us about one or more of these tools and learning more about the costs and the work needed? What's the best way to get in touch with us?
Absolutely, Rena. So I think the best way to get in touch with us is actually to use some of the contact information that we'll share with you. And I've got mine up on the screen, and you're certainly, I'm happy to receive your emails or your calls. But you can also go to askfab at fabboard.org. Naomi just put this in the chat, and I think that's the single best place to start. You can also, as I said, go to our website. You can kind of get a sense of more details about each of the tools that we have, kind of identify what might be of most interest to you. Is it the service sharing? Is that an immediate need? Are you really intrigued by this idea of a staffing calculator, because now you have access to resources for hiring workforce, but you're not sure exactly how to quantify your needs and talk about it with your board? So you can go to our website, find out a little bit more, and then use that email address to get in touch with us, and we will be in touch. One of the members of this team will be in touch with you and follow up right away.
Thanks, Paul. And one question that I think I'll address is, will there be a workforce calculator for local health departments over 500,000? And currently, the reason that we have those limitations on the workforce calculator right now is that it's driven by the data that were available to power the calculator. As more and more information around kind of costs and capacity come in to the system, as more health departments and systems conduct those types of assessments, we imagine we'll be able to use those data to better the behind the scenes of the tool and perhaps expand it to those population sizes or otherwise. So with that, we're gonna leave you, Paul. I know you'll be on and can engage in the chat for the rest of the webinar, but shift now to talk a little bit more about transformation and practice, and hear from our three panelists through our moderated discussion. We first wanted to just talk a little bit about our 21st century learning community, which is currently comprised of 18 statewide public health systems, so across governmental public health, who are using the foundational public health services or foundational public health services, plus other models to modernize and transform their public health systems. It's a learning community that was stood up in 2016. And again, the focus really is about systems transformation and across kind of statewide efforts across the governmental public health system. We are excited that our three panelists are all from states that are part of our 21C learning community, and are going to talk a little bit about their learnings, their experiences, and what's been working, what hasn't been working, et cetera. We encourage you, if you're a part of 21C, feel free to put a note in the chat that you're a part of it. If you see your state highlighted here, but you don't know that you're a part of 21C, let us know. We're happy to put you in touch with the points of contact from those states. And if you don't see your state highlighted here, feel free to reach out if you're interested in learning more about kind of what 21C is in terms of statewide public health transformation. So we're happy to talk more about 21C with anyone who is interested. I'm going to shift now to introduce our panelists briefly, and more information on each of them can be found in the bios that were put into the chat box earlier. Marie Flake works at the Washington State Department of Health, where she leads the system-wide collaborative effort to fully fund and deliver foundational public health services. She provides vision and oversights of concepts, processes, measurement, funding, currently supporting over 100 million per year in kind of transformation efforts. Her professional passion is to drive change to make systems better for all people and communities. And outside of work, you might find Marie outdoors biking, kayaking, taking photos, traveling, and just out and about exploring and connecting with people, culture, and community. Chelsea Huntley serves as the Division Director of Community Health at the Minnesota Department of Health, where she is dedicated to strengthening capacity and improving the performance of Minnesota's governmental public health system. Over the last 9 years, she's developed expertise and passion around health assessment and improvement planning, state local partnership facilitation, performance management, QI, accreditation, practices to advance health equity, and foundational public health services. And Pam Pontones has served at the Indiana Department of Health for over 30 years, beginning her career as a microbiologist in 1990, transitioned to epidemiology in 1999, and since 2009 has served as the state epidemiologist and director of the Epi Resource Center. And in 2017, she was appointed Deputy State Health Commissioner, assuming oversight of the Office of Performance Management, Division of HIV, STDs, and viral hepatitis. And she lives in Indianapolis with her husband and 2 sons. So you can read more about them in their bios, both I think from the professional side and their kind of life side. Again, are so excited to have their expertise and experiences here today. While they are all representing kind of state health departments, this really is about statewide public health transformation. And so we'll be bringing in kind of the context of how the work is connecting across various aspects of governmental public health within their states. So welcome y'all, and we're going to kick right off. And for folks who are listening in, again, feel free to add your questions to the chat box and we'll pepper them in throughout as we can. But our first question to each of you, and we'll start with Marie for this one, is can you just give us a lay of the land, some foundation setting on what your transformation effort looks like in Washington? What, what was the impetus? How is the FPHS a part of it? And just any other context you'd like to describe in terms of what your transformation structure is all about.
Okay, good morning, everyone. And if we can go to the next slide, I want to linger on this slide for a little bit here. Thank you. It's a pleasure to be here. And it's always a great honor for me to represent the work of so many colleagues, state, local, and tribal folks working together over 12 years together. So I'm going to try to give you a synopsis of that 12 years worth of work in the context in which this started. And that is that, and I'm really glad that Paul showed the Albert Einstein picture and quote. That is exactly where this work started in 2011, when once again in Washington, everybody was wringing their hands about how we needed to fund public health. Gee, is that not a new story for our field, right? And we totally took to heart the Albert Einstein quote, if we keep doing this the same way we've always done it, we really should expect the same outcome, which is underfunding. So we decided to really try to take a new approach and kind of shift things maybe about 30 or 40 degrees and come at it slightly differently. And so some of those pieces are to come at it as a system, not just state health department or not just local health departments, but to come together and figure it out together and present a common front as we go forward. We didn't come to this all at once. It's been a very iterative process. It was later in the process that we kind of had that V8 moment of it's like, oh yeah, State Board of Health and tribes are part of this. And so it's been learning as we go. So part of it was focusing our work, defining together how we want to focus the work. So focusing on the governmental public health system, that was new. We'd never used those words before. We'd always talked about public health, and we have a broad field. It's hard to know what part of this field or the system we might be talking about at any given point. So at least just to frame it in and realize that we wanted to solve a problem for the governmental public health system was one of the first starting points. Then we went on to define what makes up the governmental public health system. And you can see that on this slide here. we also spent a lot of time and work together defining the problem and then just inventing the solution together. And part of that work was trying to figure out how, part of the defining was that we wanted to fund the governmental public health system with adequate, dedicated, stable funding that was sensitive to inflation. Sometimes we would get funding into the system, but it would stay flat for 20 years. So that's, in essence, a decreasing funding source. We wanted to address all of those issues to make these services available everywhere in the state, because our partners all depend on them, and people depend on them everywhere. So from the beginning, it was about equity, trying to get these services to be delivered very much the same everywhere, in every community across the state. So that's kind of where we started. So that became part of the defining the services, defining the who it needs to get funded here, and taking this systems approach. We did all this through co-creation, working on it, defining it together. And we'll probably be saying more about that later. And then I think I'd like to go to the next slide to illustrate that there's a universe of public health and healthcare out here. And when we started this in 2011, the context was there was a lot of healthcare transformation happening. Work to try to better integrate primary care and behavioral health, work to integrate healthcare and public health. So that was kind of the environment this was happening in. And we were interested in and following along with that, but also trying to figure out how do we scope in and focus on this subset here of core services that only government provides, and thus government must fund. So one more slide to illustrate that, and I'm sure we'll be talking more about this later. This is our very unfancy, very basic framework diagram that shows we spent a lot of time defining what those services are that only government provides. They're inside that red box. More to be said about that later, I'm sure. And then we also kind of unplanfully realized that then we needed to figure out who should fund that, and went through a long process that came up with the idea that in Washington, the expectation is that state government funds these foundational public health services because they need to be more or less the same everywhere, and they need to be everywhere in the state. And that all other fund sources can be used for all those more locally specific services that we call additional partner services, the things that kind of phase out at the top of this diagram. So that's just a high level picture of kind of the work in Washington State. And I'll turn it over to Chelsea, I think, next.
Hello, everyone. Glad to be here today. Like Marie, I'm here as someone who works at the State Health Department, but really any of my local colleagues could have been here too. We really intentionally are doing this work together, and my schedule worked today, so you get me. As we just talk about kind of the lay of the land in Minnesota, we are a decentralized state, and we describe ourselves very much as a partnership. So there are key functions that the state does, key functions that locals do. And as we got into this work, realized, right, it's not quite the system that we thought we could describe, right? There's lots of variation and differences. So we do have a state health department. We have 72 local health departments governed by 51 local boards of health. So there's some complexity there in our governing structures that certainly is something that is being explored as part of this. And there are 11 sovereign nations in Minnesota. And so, you know, part of this work, again, is being an intentionally, you know, from moving from only talking about the state local partnership to figuring out how these governments work together to meet the needs across the state. And so, you know, our journey was really halted / paused by COVID. And so we have a lot of like the pre-times we were working on this. And as we emerged, took the advantage, quite frankly, of the opportunity to reorganize ourselves to do this work based on some of the things we learned. So next slide, please. I would say pre-COVID or the before times, it was really a state-led process with local input. And while we were making some progress, it really, I think COVID taught us we have to have these voices at the table together. It's not state-led. And so as we kind of reset after COVID, we established what we call a joint leadership team, and it has representatives from our state health department, so our commissioner, myself, and some other leaders within the organization, representation from our local boards of health. So we have elected officials at the table who are in charge of those local financial decisions about health. And then also local directors, so folks from our local public health association. And I have to say that has really helped move the work forward in a different way. We're talking about it differently. This work really started with concerns about local capacity and, our ability to do certain things in certain areas of the state. And it was really focused on building the capacity of local health departments. And I think as we learned from our colleagues in Washington, and as we learned more here in Minnesota, and through the leadership of our Commissioner of Health, it really became, how do we operate as a system? How do we become greater than the sum of these individual health departments? Because we know people don't stay within those county jurisdictions, and we really have to work better together. And so I think that really changed the trajectory of our work in a positive way. And bringing elected officials, those boards of health to the table, has changed how we talk about the work, again, in a really positive way, right? We really started talking to public health people about how we fund public health. And that wasn't going to get us very far. So I feel like we're in a much better place now. And what we talk about now is, that we're committed to a strong foundation for health from border to border, where no matter where someone lives, they should have the same basic public health protection. So again, moving from not enough capacity to what does it actually mean for Minnesotans has been a shift in our language. Next slide, please. So we also have a framework of foundational public health services, very much like Washington. This is agnostic of who should do the work. This is what needs to be in place across the state. And, there are real easy examples, like our public health laboratory makes sense to be centralized. Other pieces around community partnerships make sense to be very local. And there's stuff in between. And part of our assumption in really looking at this as a system and trying to fund it has been a belief that there is never going to be enough resources for all 72 local health departments and the state to do all the things, right? So yes, we need to look for an increase in funds, and we need to look at how do we do these things, not based on capacity, but what makes most sense for folks we're trying to work with in Minnesota. And so in addition to looking for funding, defining the foundational public health responsibilities, we're also looking at how might we deliver these things differently. Are there places in greater Minnesota where it makes sense to have one health department do epi work for neighboring health departments? Are there places where it makes sense, to have a tribe do one set of responsibilities and a county do another, and then they work together? So again, trying to not just say, here's what it is, we're going to stay in our current structures, but here's what it is and how do we creatively get there together? Just a note on our work with tribes, we have had attempts and fits and starts in that work. I'm really thrilled to say that we just recently began a relationship with Red Star International and Asamake, who are leading a tribal process that really is working, again, with each of those 11 sovereign nations to say, what does foundational public health mean to you? What does infrastructure look like? And how do you want to work with state and local governments? And so we're excited to be launching that work. I think I'll pause there. Would love to talk more about what we're doing, and pleased to be here. Thanks.
Good afternoon, everyone. I'm Pam Pontonis. I'm the Deputy Health Commissioner for Local Health Services at the Indiana Department of Health. And really am grateful to be joining you this afternoon to share a little bit of our journey in Indiana on public health transformation. We just started this work about a year and a half ago right now with our Governor's Public Health Commission. We saw, like probably many states, that the COVID-19 pandemic really showed a spotlight on many different aspects of public health in our state. Some of the traditional challenges we've had longstanding that really were exacerbated during the pandemic, and even some new challenges, and also where we have strengths as a result of that response. So I just wanted to highlight where we started our journey. We are a decentralized state like Minnesota. We have 95 local health departments, 3 municipal and 92 county level, along with our Indiana Department of Health, our state health department. Our local health departments, very similarly, are governed by local boards of health. Our state Department of Health has an executive board as well. And then our municipal and our county health departments are governed also by their county commissioners, their county councils as well. So in 2021, summer of 2021, our governor, Eric Holcomb, looked at what was going on as a result of the COVID-19 pandemic and decided to really conduct a comprehensive review of our Indiana public health system. And we really define that as very similarly as including our local health departments, our state Department of Health, our boards of health, our healthcare partners, our community-based organizations, our educational institutions, and many association partners as well. It's really a system. And from the very beginning, took a systems level approach at reviewing our public health services in Indiana. So our governor convened really a blue ribbon 16-member panel that included representatives from local health departments, including local health officers, administrators, included local elected officials, association partners, for example, from our Rural Health Association, our Public Health Association, our Indiana Minority Health Coalition, as well as others, and really looked at researching and assessing where we are in public health around 6 different work streams. And those included workforce, funding, governance and infrastructure, data integration, childhood and adolescent health, and emergency preparedness, all of which really rose to the forefront through our pandemic experience. We did quite a bit of research in each one of those areas. And the area of research in which I was very active was the governance and infrastructure work stream. And through that research is where really found out so much about the foundational public health services and 21st century states, and became very involved in understanding how that worked. We provided the commission with the information that we had gathered through research and with our partners through interviews and surveys and conversations, and shared where Indiana really sits with those different work streams. The commission then took that information and developed 32 different recommendations for public health improvement in Indiana. And that is all described in a very comprehensive report that you can find on our website at www.in.gov/GPHC. And those recommendations now that have been issued, the next step is to be able to get state level recurrent sustainable funding appropriated to fund those recommendations, not in the form of a grant, which we know can be temporary and change and fluctuate. But again, as you've heard our other panelists say, sustainable recurrent funding that is appropriated continually. Next slide. So one of the first recommendations that made through our Governor's Public Health Commission was defining the core public health services in Indiana that all Hoosiers can expect no matter where they live, from the smallest rural counties to our largest local health department here in Indianapolis and Marion County. And you'll see on the slide where our foundational areas are, and they really mirror the foundational public health services and include some of those capabilities as well. You'll see at the center it being equitable delivery of those core public health services. So when we right now are in the process through our budget bill of requesting that funding appropriation from our legislature, and our local elected officials have the choice to opt in to receive that funding according to a set funding formula, or they can opt out, receive the current funding that they get now. The increase is substantial and going essentially really averaging $30 per capita across 6.8 million people. So that is really the most substantial increase in state public health funding we have had in our state. Next slide. As local elected officials opt in to receive this funding, then they agree that the local health departments will provide those core public health services in their jurisdictions. And that doesn't mean that they have to provide those services themselves, but they can also engage partners in their communities to be able to provide those services as well. Essentially, it's up to our local health departments to ensure that those services are available in every community. So we have defined our core public health services last fall through our core services committee, which included local health departments, healthcare partners, and others to really define what those are. And then we now at the Department of Health are looking to use our CDC public health infrastructure funding, at least to start, to create strategically placed support teams in different areas of our state to provide direct support to our local health departments in areas that we heard, especially through the pandemic, where they really could have used some help. Our legislation also ensures representation of municipalities on local health boards and allows for greater citizen and local elected official engagement. We've also expanded the folks eligible to serve as local health officers in our local health departments in Indiana. And we've really promoted local health department engagement with local businesses, healthcare providers, schools, and other governmental and non-governmental organizations to really strengthen and build partnerships, because that really will be where our local health departments' best allies will be, especially as they move forward in our rural areas, or maybe traditionally areas that have been underserved and underfunded. We also, through our resources here at the State Health Department, look to provide financial and technical assistance to local health departments pursuing accreditation or re-accreditation. And that support is actually built in to our CDC Public Health Infrastructure grant, and then also through our support teams. Next slide. This just very quickly shows you a quick graphic of the core public health services that relate to those foundational areas that I showed you. They're kind of broken down into some of the areas that are, or services that are required by statute, or also that we have found that are readily available in some of our local health departments. Next slide. And just wanted to wrap up on the focus on equity that we have, again, at the center of the work that we are doing through our Governor's Public Health Commission, and the work that we will be starting in providing those core services, and really to improve the health of all racial and ethnic populations in our state. And we're happy to answer any questions that you have at this time.
Thank you to the three of you. We really wanted to do some foundation setting around kind of the what and the why as we then transition into moderated dialogue. So appreciate y'all taking the time to just give us a lay of the land around what's going on. And I'm sure everyone's hearing kind of similar themes emerge in terms of really taking that intentional look at what the system should look like. What is core public health within our statewide system? using the foundational public health services, but you saw like slightly tweaked versions perhaps in each state based off of the national framework. Really, how do we think deliberately about getting sustainable reoccurring funding for public health? And how do we think about different ways, innovative ways that we can provide public health services, structure ourselves to truly have kind of equitable public health systems? So that's what I heard, in addition to a lot of different things as kind of themes across what y'all shared. And I wanted to dig in a little bit deeper on some of the points that several of y'all mentioned around partnerships with tribal public health, and would love to hear a little bit more just in terms of public health modernization across the system, including tribal public health, and what those conversations have been, how that work is going, and just anything else you'd like to describe. So I'll ask Marie to jump in first on this one, if you're willing.
As soon as I get myself unmuted, I'm happy to. In Washington, a tribal government, let me get my language correct here, sovereign tribal nations and Indian health programs, that is the definition of that part of the governmental public health system, has participated actively since 2016 in this process and has had seats at the steering committee and as one of the 4 co-chairs of the steering committee, and then also working in different committees and things like that, while running their own tribal foundational public health services work group to really walk through their own tribally led and state health department supported process for sorting out what foundational public health services means in a tribal context. And they've made amazing strides on defining a diagram and definitions about foundational public health services in a tribal context. The governmental structure and expectations of people of what they get from government is a little different in a tribal setting. So they are building that out and designing that, and have completed an assessment of how much of those services exist, and are now having funded projects to begin to develop the services and infrastructure needed for those services.
Thanks, Marie. Chelsea or Pam?
Yeah, I'll just go build on that. Similar in Minnesota, different iterations of our committees have had tribal members on it, and it hasn't felt like a great fit because we fell down in the tribally led state health supported area. And so we were fortunate to get some resources and are funneling those resources to that tribally led process. So that can happen, and not just say, hey, we created this framework over here, do you like it or not, right? And so that's kind of where we're at right now. And I will be thrilled to come back with our tribal health departments in the future to kind of talk about how that works. I think I'm thrilled to be learning in the coming year about, you know, where each of the 11 tribes are at in Minnesota and how they're interested in working with the state and locals.
Pam, is there anything addition? Not we can.
No, I really don't have a whole lot else to add other than, you know, we have folks from our minority health and health equity division that do partner with our associations that are engaged with tribal health and tribes here in Indiana. So we don't have maybe quite the level or degree of that of tribes that other states have, but we do engage with those associations, those representatives, to make sure that their voices are heard and included as well.
Thank y'all. And in a similar kind of vein, wanted to ask, and Pam, your last slide kind of spoke to this, so perhaps I'll start with you on this one. As we think about equity, there's a variety of different layers in terms of equity and public health modernization. There's equity, which is a foundational capability and surrounding the entire framework. There's building and reimagining public health to truly build equitable, community-centered public health systems. There's addressing inequities on the day-to-day basis. There's a variety of different elements, right? How would y'all define kind of equity in your transformation work? How are you addressing those various layers and others? And what do you mean when you talk about kind of equity being a part of your process? So Pam, I'll start with you, as I know you touched on that in your slides.
Sure, and thank you so much for that question. And when we look at equity, we really, where we started with is all Hoosiers. And we know that there are different maybe aspects of equity, looking at race, ethnicity, looking at age, looking at geography such as urban versus rural, looking at gender, looking at income, looking at many different facets of equity. And when we looked at our core services, that's where we felt that it was essential that all Hoosiers, no matter where they live, have access to core foundational public health services. So as we defined those last fall, we did that with that equity focus in mind. And we have some prevailing equity themes that we use in the development of those services. Also, right now, we are engaged in developing the key performance indicators to measure how well we are delivering those core public health services and building equity components into those key performance indicators as well.
Thanks, Pam. Chelsea, Marie, I'll open up to either of you.
Well, I'll try to jump in. Absolutely, it's baked into the foundational public health responsibilities. I can say when we initially developed our framework, lots of conversations. Is it cross-cutting? Is it a zone? How do we reflect it, right? And so I think if you kind of look into any of the frameworks, you'll see equity practices as it relates to data. What do we collect? Who do we work with? How do we analyze it? You'll see it in the community engagement components. You'll see it in the, is this upstream work or is this direct services, right? So I think you'll see it in all sorts of places, and we continue to evolve. I mean, one of the conversations right now is who's at the decision-making table. Yeah. We're pretty good at getting input, but we're not as good at saying, okay, well, who are the folks that need a seat at this table when we decide what it is that government does for who? And so we're evolving, I will say, but it's a constant topic.
And I would say ditto for Washington for both what Pam and Chelsea just said, including that we are evolving. And so we are just beginning to dig deeper and figure out how to have conversations more about peeling that onion and more digging it down more about how we actually implement the funding allocations and the work to actually address inequities. Our definitions, very much like Chelsea said, talk about using data to identify inequities, working with partners to address them. And now we're just beginning down the road further about, let's get more clear about that. What does that mean?
So I appreciate all the questions that are coming in, and I'm going to keep us moving because I want to try to answer as many of those as we can. I'll ask y'all, we've gotten some questions around this, and Pam and others, y'all spoke to this a little bit already. Can you talk a little bit about how your history of kind of transformation, modernization, focusing on kind of building capabilities in areas of public health, and the new recent CDC infrastructure funding work is coming together? How are you using that to advance your work around modernization transformation? How are you using it to invest in capabilities, workforce, data modernization? And, can you talk just a little bit about how those are coming together and what you're focused on with the infrastructure funding?
Sure, I'll go ahead and start. That's a great question. And really starting from a very data-driven approach. So using the data that we collected is in the research for our Governor's Public Health Commission, defining the data we gathered around defining our core services and now around our key performance indicators, really has helped kind of direct what we're doing. In terms of the CDC Public Health Infrastructure Grant, we looked at how we could best utilize that funding to support work in those different work streams, and really what the grant was meant to do. So in the area of workforce, really looking at how we could build our teams to support local health departments. That for us was absolutely critical. We know that local health departments in many ways have been maybe traditionally underfunded, understaffed. We heard through the pandemic that they really needed support in certain areas that they just may not have had, such as communications or legal support or data analytics, quality improvement and accreditation, a number of different areas. So we are building that support, those teams, to provide those direct support links to our staff here in Indianapolis, but where they are. And that's very important to us, is being able to provide that assistance where they are. We also are looking to build out our teams here to help support accreditation and quality improvement efforts that drive so much of this work, especially as we measure success and gather the data continue to gather the data that will help show that. Also looking very hard at what we can do with data modernization, with building out our teams here to provide dashboards, to gather and analyze data, to be able to provide data to the local health departments and their partners who really need it, to measure how we are providing that core service delivery and what we're doing. So we're actually starting to the plan is to use that funding in those activities and looking at hard how we build out additional support teams, even at a district level, with community health workers, with epidemiologists, continued support. And then as that funding begins to die out, we will then use the sustained state funding that we will look to be appropriated to continue that work.
Marie?
I would just say that overall it's still evolving in Washington. And I think is that where FPHS can be really useful in the CDC infrastructure grant allocations and things is that FPHS gives a little more frame and detail around workforce and data modernization and everything under that. The foundational public health services work we've done really operates in and defines things as services that will actually be provided. We just had this conversation yesterday related to a different topic about workforce is really important. We want to fund workforce, we want to hire workforce, we want to train workforce, but somewhere we have to describe workforce for what. And so the foundational public health services help frame out those activities that only government does and that we need that workforce to be doing. So I think we're still evolving about how the CDC infrastructure grant will fold into that and hopefully dovetail with state foundational public health services funding, and hopefully be part of the consideration of the FPHS steering committee as they are allocating resources and also keeping in mind this other revenue stream that's available to help fund some of this.
Yeah, I will say similar to Pam's comment, we're using those funds to fill identified gaps and capabilities, right? Capabilities that we heard over and over and over again, both before COVID and during COVID. So not a long-term solution, but something that we felt like we could plug some holes in now. So just a few examples, definitely data, both making sure that we have a system statewide, state, local, tribal look at data modernization and making sure that there's enough engagement in that, and it's not just the state doing it on its own. Some staff at the state level to really support data collection and data analysis at the local level, particularly in some of our smaller health departments. We're actually bringing on some communications staff specifically to work with and tailor messages for rural Minnesota. Just a real recognition that like this one message isn't going to resonate. You really need folks who live in rural Minnesota and are able to adapt to messages appropriately. And then quite frankly, a fair amount is going into the state health department operational functions, right? Our inability to hire and or get money out directly impacts how our public health system functions. And so while I wouldn't say there was a, because of public health system transformation, we're going to do this, like it's all addressing those, the similar gaps that we're trying to fill and on a long-term basis.
Yeah, and I have two related, but I'm going to ask them separately questions. So just remember that I have two. For the FPHS model, there's the foundational capabilities and foundational areas, and then there's community specific services. And we're getting a few questions in around kind of where do things fit in the model if you don't see it explicitly around capabilities or areas. And I'd just be curious from a kind of identifying and understanding what core services are within y'all's state. And generally, I know y'all have kind of thoughts about that. So I'm going to start with Marie on this one and see what your thoughts are on that question.
Great, thank you, Rena. And I'll just acknowledge here that I'm going to have to leave a little early of this session, so I'll be around for a little bit, but then I'll be stepping out. And I'm wondering if, Travis, could you go back to showing that slide that is our framework, the gray slide with the red box, and use that to describe that? Because I did see a question fly by about, where are kind of senior services and aging? I'm sure people have other questions like that. And it's slide 11. Thank you, Travis. And so the way that we think about this in Washington is that there are these cross-cutting capabilities, or also called foundational capabilities. And then there are the foundational areas, as Rena was talking about, and there are specific definitions for all of those things. And the specificity level, the goal when this was all defined out was to be general enough to stand the test of time, because we are trying to get away from the whiplash that's created from flavor of the month funding or crisis of the year funding. We wanted to create what is it that is ongoing for governmental public health that we always have to be there providing, and yet specific enough so we could measure it and kind of across our state, 35 local health jurisdictions, 29 tribes, state health department, state board of health, that we would all kind of know what we were talking about. And so when it comes to specific conditions, diseases, topics like aging, like opioid crisis, things like that, people are always saying, I don't see that in here. Well, for those two examples, for example, that would actually be into this chronic disease and injury prevention section. And the definitions that reside underneath that red line are that the government's role is to collect, analyze, and bring forward data, including on inequities, to work with partners to identify assets and resources and priorities and a plan, and then go find the funding to implement those activities, and then to coordinate all this together. Whatever the topic, if we'd had this in place along with the assessment foundational capabilities, maybe in public health, we would have seen the opioid crisis coming earlier and been able to take more action than finding out about it in the news like everybody else. This is the core that we're trying to fund, is that stuff that's hard to see, that doesn't always reach out and individually touch people, but it is essential, and it is the foundations on which everything else depends. We've got public health work and our partners work. So that's kind of how we see that.
And Marie, I know you have to hop. So before Chelsea and Pam, y'all hop in, I'm going to just ask you another quick question before you have to leave us. And that's, well, one, just anything you'd like to leave with the group today. And then two, if you could just briefly describe, we had some questions come in about how do you understand the cost and capacity that exists and what's needed to be able to make these types of decisions. So I know Washington and others have done work in this area. So two questions for you before you leave us.
Okay, let me see if I can do that very succinctly. And I'm going to use it as a platform to display two other slides, Travis, number 16, and then we'll go to 17. And that is the orange bar chart, because I just want to say that we did a statewide assessment to measure how much of these services exist now and how much funding is needed to make them fully exist. And so the baseline is that very first column, which shows the need statewide across state and local public health. Tribes did not participate in that assessment. They'll be incorporated in the future. But it was $225 million in addition to money in the system at that time that was needed by estimate to deliver these services. I have other slides that come from that assessment we'll talk about in a minute. But one of the questions I know that Rena had queued up for us was about progress and how we're tracking and measuring that. The dark colored bars there show the funding that is now coming from the state legislature into the governmental public health system to address this gap. There's a lot more other detail in this, but I just want to say that we are making good on our stair-step, long-term building block approach to achieve stable funding. These orange bars here that continue stable, that's ongoing commitment from the legislature to fund. and we're going to keep layering on the next request on top. So we have measured this. It's all based on estimates, but an estimate is better than nothing. We use BRFIS data all the time in our work, behavioral risk factor surveillance system data. That is based on self-reported data from the general public. It's a good data source if you collect it consistently and repeatedly, and that's kind of the way we're doing our data collection. The other part of progress I'd like to show is if you could go, Travis, to slide 18. And then, because we also measured how much of these services exist. And in this illustration, this is a sample of data rolled up very high level from communicable disease definitions of foundational public health services. The vertical line in this image shows where we were at baseline. And the gray-blue lines then show the measurement in subsequent years after investments were made in these areas. And part of what we're learning is what we had expected, that you can't make complete progress with one lump sum investment. It takes ongoing, iterative, layered, year after year investments, and you can see progress over time. That's how we're interpreting this data at a very high level. But just to illustrate that measurement is possible when you have definitions, so you're all talking about more or less the same thing, and you don't let perfection be the enemy of the good, and you do the best you can to measure a system. So those, I think, were kind of got to your questions, Rena. Is there anything key I left out that you would like?
That's perfect. Thank you so much. And thanks for being here today. Chelsea and Pam, I'll see what thoughts y'all have both on the question around kind of community specific services in addition to the capabilities and areas, and around, I know Minnesota just completed and process of completing a capacity and costing assessment. So thoughts around both of those questions.
Yeah, I'll just reiterate in terms of what Marie said, in terms of the foundation is no way to take into account all the work that health departments do. And in Minnesota, you'll notice our framework, we call it the foundational public health responsibilities. It focuses on the responsibility of government, which is different than, sometimes we get mixed up with services provided by DHS or other entities, right? So we took very thoughtful approach to say, this is about what is government's responsibility when it comes to public health. And so you're right, if you look in there, you're not going to see those specific categorically funded programs. You're going to see the things that we want in place across the state. And it allows space for communities and the state health department to say, hey, here's a need now. We're going to fill it, with this grant fund. We're going to fill it with tax levy. We're going to fill it with foundational money, whatever that is. But kind of the thinking behind it was, for so long we've been chasing the programmatic dollars at the expense of those skills, capabilities, and the ongoing work. So as Marie said, we're looking for things. We're bringing together partners as it's happening, not, oh, now we have something going on, we're going to spin up a program to address it. So, but it's been hard conversations across the state because there's a real fear, right? If I don't see my thing in the foundation, right? A, that's my work. That's what I come to do every day. And B, if we're going to seek state and federal funding for that, who's going to pay for this program that is really important in our community? So it's not simple, but it is intentional to say we have to have this base and can no longer kind of have each community doing different things at the expense of a strong foundation.
And I would just mirror a lot of what Chelsea has said. In Indiana, we looked at what public health services are actually required by statute, and then what services that we see that are provided in many of our local health departments or communities through community partners, but maybe are provided in different ways to different degrees, or maybe in some instances not at all, but are nonetheless important. So we looked hard at those, and really when we worked with our core services committee, got input from healthcare partners, got input from our local health departments in a very big way, so that again, we're looking at folks who will be providing or ensuring the provision of those services and where they are right now and what their needs are. Okay, it's great to say this is a service, but we need training, we need help. To be able to do that. What partners can you put us in that direction? And so there's a lot of work that's been done here and I imagine with other states, to help local health departments find those community partners. We've built in training to our public health infrastructure grant and work that we're going to be doing moving forward as we develop our key performance indicators is great, but what training might be needed around that? And then we can use our regional or our strategically placed teams to help with that, as well as the field teams that we have in place now. The core services model that we developed was meant to be very flexible and use of funding where local health departments really need it. So you might have a local health department that's doing a great job in the maternal and child health space, but they really need some attention and help in the emergency preparedness space or chronic disease. And so they can use this funding. And what we've done now is encourage our local health departments. The time is now to convene your partners and to really assess where you are right now with your local health boards, your partners, the local elected officials around those core public health services. Which are you doing well? Where do you have gaps? What do you even need to start? And then you can use this state funding to support that. The grants are going to stay the way they are. You can use your dedicated grant funding to support what you're currently supporting, but you can use the state appropriation funding to fill those gaps that you need specifically in your communities. So again, getting back to a very data-informed, data-driven way to start, and then being able to strategically apply those funds where they're most needed in that particular county or community.
Thank you both. And it's hard to believe we're almost at time, and there's a long list of questions that we'll be sure we get responses to and can send out and follow up. A couple of thoughts I had in thinking about those two questions too. The foundational public health services model, the national framework, and otherwise really is about kind of what's the responsibility of governmental public health in terms of the capabilities and areas. As y'all and as Marie have all said, that's not to diminish anything that's considered community specific services. Those are equally, if not more important, but we need those foundational pieces to be able to do everything else. We need the cross-cutting capabilities in areas to be able to then do the rest of the work that public health does. So it's not to kind of lessen if there isn't a specific topic or program area in there, and it is meant to be in community specific services or otherwise, but really those two pieces are what's foundational to be needed to be able to do everything else. We have 2 minutes left. So in your quickest pace you've had all day, I would just ask both of you what advice or just one lesson learned or something that you're really proud of that you would like to leave with the group today. So any of those pieces of that question that you'd like to respond with.
I would say really that I'm so pleased and proud of really the way we have been able to learn from other states who've gone before us in this work. Their partnership, the work that PHNCI has done, being part of this consortium 21st Century States to begin getting information has been so helpful and to learn the journey of others, and very grateful for that. I think gathering your data, really doing an honest, comprehensive assessment of your public health system, and then using that information to help drive your next steps. And I think when you look at really looking at where you are in your public health system, as far as where you're strong, what your strengths are, where you have gaps, what you need to start, and then really being able to apply the resources where they're needed with equity at that focus, and then using data to measure the success. The foundational public health services we found was a great place to start. and really form the framework for what we are doing right now with our core public health services. We found that what we required in statute really is very similar, and the other services that are being offered as well. So I would say that that would be my thought, to at least get started.
Wow, so much to say here. So I will say, really engage others early on. Like I said, Minnesota made some missteps, especially if you have tribal nations in your state. Talk to tribes early to see, the interest and what's happening in terms of their public health work. I said it early on, we needed our community health boards at the table. We were talking to ourselves and it was not moving very far. So appreciate hearing from Pam how you've engaged some other partners. We definitely need to do that. And then in my mind, this is about the system as a whole. And so give yourself the space and opportunity to think about how you're organized. Yes, this is not about, merging health departments, and it is about saying, is there a different way we could fulfill that responsibility, that capability, et cetera? Like, because again, we've all seen or been in health departments where, it's your 5 hats. And I would argue that those 5 hats aren't always the most effective way to fill those capabilities, right? So how can we be creative that both, leaves local control strongly in place where it needs to be and gets our needs met in a way that that is more effective than what we're doing right now. So happy to talk to folks anytime. This is work that's just really near and dear to my heart, and thrilled to be a part of 21C states who are trying to make the system work better.
Awesome. Well, thank y'all both. Thanks to Marie too, had to leave. Thank you to Paul. Thanks to Travis and Naomi and others who have been behind the scenes, and just hope that this has been helpful. We'll continue to think about what would be helpful to y'all who are listening in. Let us know, and we can put together additional programming too. Just a couple of closeout remarks. One, I know there's been some talk about measurement and indicators and how do we understand. I would also encourage folks to look at the foundational capability measures in version 2022 of the FPHAB standards. We are going to be launching a capacity and costing assessment. That'll be our March Innovation Series webinar that's really supporting statewide public health systems. So not just an individual health department, but across your system. How do you understand what you're currently spending and your current capacity is towards the foundational capabilities and areas? How do you understand what full implementation might cost and look like? And how do you then address the gaps that have emerged, both from a costing standpoint and a capacity standpoint? So look for that coming in March, and there will be a webinar. And again, feel free to reach out to us. I know there's been a variety of contact information and links put in the chat box. We're always happy to talk about what else would be helpful, in particular as y'all are working on public health modernization and transformation. So thank you. We'll follow up with the questions we didn't get to, and we appreciate y'all being here today. Thanks to the panelists, and we'll talk to y'all on the next one.